Important progress.
Inspired by God, when we are called, the martyrs from Uganda, so our courage and our hope, guide us in virtue to lead the world, build through may we remain faithful to the name Uganda Martyrs University, a place of love, where it is good to be. Guide us in wisdom to lead the world.
Let us take our seats, please. Dr. Elizabeth Amalfi, the Dean of the School of Postgraduate Studies and Research, dear professors, Mr. Richard Kabanda, Dr. Angus, at today's doctoral defense, dear colleagues, ladies and gentlemen, good morning. You're all welcome to this academic event, at which Mr. Richard Kabanda is going to make an oral presentation and defense of the research that he has undertaken. The title of his research is the use of community audio towers in health communication for prevention of cervical cancer in Ugandan rural communities, the case of Kyotera district. Which looks like interdisciplinary research, I think will show us. This journey has been accompanied and supervised by Professor Edward Manico, Professor Manico, most of Uganda Matters University. Professor Manico is a professor at Kabanda University School of Medicine in the Department of Public Health. And I think you know he holds a PhD in health systems research from the Royal College of Surgeons in Ireland, and he achieved that in 2015. We have on the panel very senior people to examine Mr. Richard Kabanda. We have Professor James Kimwine. Professor most welcome to Uganda Matters University. Professor Kimwine has a very, very rich CV. I will not go through it all this morning, but just to highlight a few things. He holds a Bachelor of Medicine and Bachelor of Surgery degrees, and the Master of Medicine from Makerere University, holds a PhD from the University of Belgium, and is a Fellow of the Royal Society of Health in the United Kingdom and the Uganda National Academy of Sciences. He is a very prolific writer. He has written over 200 scientific publications in peer-reviewed journals, 2 books, and contributed book chapters in a number of books. He has supervised over 30 masters research done by students, 15 PhDs, and even postdoc fellows. So he is a man with very, very wide experience, both in the academics and in community life. Just one little thing, at community level, he chaired Kabanda University Council for 8 years and has contributed to its growth and eventual movement to being a full-fledged government institution. He chaired Kabanda Search Committee for DPCs. He also chairs the Government Council for the National Teachers College, Kabanda. He has wide corporate governance experience through chairing the Joint Medical Services as well. He's the current founder, chair, Uganda Health Communications Network. Professor. We have Professor John Charles Okiria. He's a specialist in pharmacy management, and he is a health economist. Currently, he's a teaching professor, a dean of the Institute of Allied Health Sciences, chairperson, Allied Health Professionals Council Uganda, senior program assessor for National Council for Higher Education. Before his early retirement from public service, he was the head of pharmaceutical services for over 18 years. Professor, welcome once again. We have Dr. William Taiwa. Dr. William Taiwa is a renowned media scholar and has explored media in diverse ways as a lecturer, as a journalist, as an editor and publisher. He holds a doctorate in communication, peace journalism and communication from Concordia University, Montreal in Canada. In addition to so many, he obtained his Master of Philosophy in Media Studies, Environmental Journalism and Communication from the University of Oslo in Norway, and the Bachelor of Mass Communication from Makerere University. His areas of teaching at graduate and undergraduate levels include development, communication, media, and theory. He also headed the Makerere University Department of Journalism and Communication since 2014 until very recently. I'm not reading everything, you will understand. I'm just highlighting the key things so that we know we have an idea who is with us. Then we have Associate Professor Laura Aliko Otala. This is one of us here at Uganda Matters University. An Associate Professor in the Institute of Languages and Communication Studies at our university. where he serves as head of the Department of Languages for a number of years now. She holds a PhD in language and higher education from the University of Western Cape, Belleville, a master's in education and bachelor of education, all of which focus on English language. So you notice that the correctors are from a variety of areas. As I said at the beginning, the research of Mr. Kabanda is interdisciplinary, and that explains why we have such a wide range of stories. I'd like now to ask me some open remarks before Mr. Kabanda, and she will tell us how it will proceed. My work is just simple, just to coordinate the activities of the team, please.
Thank you very much. This is that I propose. I add my voice so that the MC will come. You, my dear examiners, the supervisor, Richard. Richard, you are most welcome to arrive at this milestone. As we all know, the oral defense is another form of examination. After the examination of the thesis has been done, given the nature in which we are living now, we couldn't do it otherwise, except to have some people online. Without wasting time, I would like to invite Richard to come and present to us his work, how we went about it, what findings we arrived at, and what recommendation he makes for us. Richard, you're welcome. You will present for 30 minutes, and then thereafter you will be interrogated by the members of the panel, and we give you the opportunity to respond. Welcome. In the meantime, probably members might have to go at the other side, so that you can be able to see the screen as it presents. Thank you very much.
That's what I thought. The topic I'm looking at is use of community audio towers in health communication for prevention of cervical cancer in Ugandan rural communities, the case of Kyotera district. So briefly, the outline for the presentation is within the areas provided for as per the SPGS 2016 guideline for PhD students. So this PhD
domestication is within public health, but within the specialty of health promotion, but more inclined within the focus of health communication. And health communication is a multifaceted and multidisciplinary approach on how different stakeholders can easily be reached with health information with the purpose of changing their behaviors and practice, which ultimately leads to improved health outcomes. And the focus on community audio towers. Community audio towers are a community-based channel of communication, which comprises of powerful fixed speakers hosted on poles that can send information in communities up to a range of 5 kilometer radius. So that demonstrates how different community audio towers are being fixed in different parts of communities, depending on a number of factors as the owners or the community may deem fit. But briefly about the key characteristics about community audio towers. These are locally owned and operated by people within that geographical area. And the language or mode of communication is usually the local language for that area. And messages are freely consumed by the recipients. So this is the only channel of all the different channels of communication where an individual in a community can easily access information without incurring any cost. All these other modes, whether it's radio, TV, or it's screen media, among many more other media, somebody has to incur a cost. It may be directly or indirectly, but this form of communication, one doesn't actually require to incur any cost. And of course, we know that it's close to community and they cards can easily be accessed by the community. Briefly about cancer. Cancer is one of the leading public health challenges globally now, with over 19 million new cases. And of these, 5.7% of these are in Africa. But of course, bearing in mind that in Africa, we know that some of the key challenges we have, especially with the cancer registries, it is highly suspected that this percentage can actually is actually higher. And of course, globally, getting to cancer of the cervix is 7th most common among all cancers and 4th common among women. And we know that over 600,000 new cervical cancer cases annually are in developing countries, Uganda inclusive, and 15.3% of these are mainly in Africa. And over 260,000 deaths annually. We see that 21% of these, as a result of cervical cancer, are within Africa. And of course, getting it closer to Uganda, over 19,000 cases are seen among females, but of these, cancer of the cervix accounts for 35.7%. In terms of death, still it is the same. Cancer of the cervix accounts for 20% of the cervical cancer there. So literally, if you look at that kind of statistics, in terms of incidence for cancer, most of the developed countries actually are ranking high, but in terms of mortality, less developed countries, Uganda inclusive, we actually ranking high. So that is mainly due to late presentation of most of our people from rural communities or from communities to hospitals. So the main key issues here relate to low cancer literacy and inadequate scaled up programs that can support cervical cancer prevention in the country. And of course, routing community audio towers and health communication. We know that these are community-based, and one way how we can improve health literacy, which is the engine of cervical cancer prevention, and of course, the engine of disease prevention. We need to utilize community-based resources to be able to increase information sharing, which is geared towards increasing health literacy, which eventually can lead to adoption of desired behaviors and practices. So we know that cards are close to clients or communities, so they can easily be used for that purpose. But we have not seen that happening adequately in the country. Having said that, cervical cancer is increasing a public health challenge with high mortality, mainly due to late presentation of individuals to hospitals. So usually what happens, there is late diagnosis and treatment. And as I said, this is majorly attributed to low cervical cancer literacy. CATS would have bridged the gap of increasing cervical cancer literacy, but this has attracted minimal attention among different stakeholders, from policy down to those who are involved in implementation of health promotion or public health related programs. So CATS currently are only being mainly used for commercial and social marketing purposes in communities, with little focus on health issues. And of course, we know that lack of knowledge on efficacy and effectiveness of CATS, which currently has not been available, denies health policymakers and implementers and those involved in planning of public health and health promotion programs to utilize this key resource in increasing health literacy. So this study tested the efficacy of CATS in health communication for prevention of cervical cancer, on top of looking at the availability of CATS to healthcare professionals who are the primary professionals that are manned with educating people in communities. And of course, also partly looking at factors that affect their use in communities. The key research question here was, does use of CATS in health communication promote adoption of behaviors and practices that lead to prevention of cervical cancer in Ugandan rural communities? The three key specific questions: one looks at availability of CATS, the other looks at factors that affect use of CATS, and the third question looks at efficacy of CATS. The specific objectives: number one, to determine the availability of community audio towers or CATS to health workers for use. So the availability is for use in health communication for prevention of cervical cancer. Number two, to examine factors that affect use of community audio towers in health communication. And number three, to determine the efficacy of community audio towers as a health communication channel for prevention of cervical cancer. So in this study, CATS were looked at as a superior in terms of delivery of key messages to communities, to the geographic communities where they are located. And with that, it required a study proposition. And the proposition for the study is use of community audio towers in health communication can lead to significant increase in health literacy, thus adoption of recommended behaviors and uptake of cervical cancer preventive practices like screening, which is a common or a key preventive public health measure for prevention of cervical cancer among individuals in communities. My conceptual framework looks at a number of key areas that support use of community audio towers, like availability, regular use by healthcare professionals, efficaciousness of CATS as a channel, and then factors that support individual health workers, the health system or health facility factors, and then the community factors that actually enhance use of CATS. So once this is positively done, it automatically leads to cervical cancer, increase of cervical cancer health literacy, and increase in risk perception and cancer awareness. We know that when risk perception is high, then chances are high that members of the public can actually be able to adhere to the promoted behaviors and practices. So that literally leads to avoidance of cervical cancer risk factors, and of course also adoption of the practice of early screening, which leads to early detection of cervical cancer. So once that is done, literally it leads to reduced cervical cancer morbidity and mortality, and of course also reduced cervical cancer incidence. There are a number of theories that were reviewed, and there are a number of competing theories. But the most eye-catching theory here is the socio-ecological model, because we are looking at the use of CATS in the community beyond an individual and the community where they are. And of course, we also know that the environment and the organization key factors, the health facility factors that actually support health workers to use them, as well as policy or strategic directions from policy makers that actually synergize use of CATS for effective health promotion, health communication service delivery. So the theory adopted is the socio-ecological model and has been used all through. It has key different layers, which has actually been used also to come up with the a theory of change, as I will illustrate. The philosophical perspectives, the study adopted the post-positivism with the philosophical views from critical realism, and this guided in coming up with the key methods, because we know that the post-positivism believes in having a mixed methods approach, which was adopted here. It also looks at understanding the causes and outcomes of particular key issues. And of course, statistical objective number 3, which was experimental, was able to bring about this key philosophical grounding. Research methodology, this study has 2 sub-studies. Sub-study 1 looks at statistical objective 1 and 2, and then sub-study 2 looks at statistical objective 3. And this is because sub-study 1 can be able to respond to the research question 1 and 2, and then sub-study 2 can be able to answer the statistical objective 3. In terms of compliance with ethical guidelines, this followed all the recommended processes from Uganda Matters University to IRB for approval of such protocol. That was my email. I received technical clearance from Ministry of Health, and then final approval from Uganda National Council of Science and Technology, and then local clearance was sought from Kyotera district leadership or administration, and then informed consent from participants. So I'm going to present the methodology for sub-study 1 that touches objective 1 and 2, and then thereafter I'll provide results for sub-study 1. So after that, I'll then be able to go to sub-study 2, provide the methodology, and then results in that order. So sub-study 1, in terms of design, I adopted a cross-section analytical design with concurrent mixed methods. So the findings from both qualitative and quantitative were integrated at the interpretation stage. The study population here, I looked at health workers who have been working in Kyotera district for at least a year, and within the public service or within the public health facilities. So the sites mainly were public health facilities from Health Center 3 up to General Hospital, and simple random sampling framework was adopted. So for quantitative, self-administered questionnaires were given to health workers, and for qualitative, in charges of health facilities as well as operators of CATs were able to provide data. So using the Kish 1965 formula, I did get 385 study participants, but because the health workers who are in Kyotera district were not up to that number, they were 271. So I adopted the Cochrane's finite population correction formula to be able to reduce on the sample size. And then this gave me 160 study participants. Adjusting that with 10% for non-response rate, it gave me 176 study participants. But on recruitment, those who finally provided information were 160 study participants. So for the qualitative part, it mainly followed the research principle of saturation, and participants were purposefully selected, as I indicated earlier on, that in charges and operators of CATs. And of course, these were interviewed one by one, and analysis of data was done on a daily basis. So in total, I had 9 health workers and 6 CAT operators, giving a total of 16 for the qualitative data. In terms of analysis, I used Stata. So univariate analysis to provide distribution of respondents for the different factors. And then that mainly touched statistical objective 1, and then bivariant and multivariant provided key analysis for specific objective are two mainly. Results. So what is key here is that most of the health workers that participated had spent between 4 to 6 years in service, and many of them did not have any family cancer history. We know that presence of family cancer history contributes significantly to health communication practice among healthcare professionals, as I illustrated. And in terms of availability, so it is just very clear here that cards are actually available to health workers for use in health communication for all the different parameters that I measured in terms of workable distance, in terms of easily storing airtime, and of course also in terms of easily accepting either printed or audio recorded. All these significantly actually indicate that they are available to health workers. So that is still the same way for the qualitative results from the in-charge. Most of the in-charges indicated that cards are available, and similarly to cards operators, they indicated that the cards are easily available for use to health professionals when actually they're thought for. So in terms of frequency, in terms of use of cards, mainly use of cards, I looked at 3 key issues. A health worker being able to send a pre-recorded message so that it can easily be aired the way it is, or a health worker being able to send printed material that is in the local language so that the operators of cards can easily read them, or health workers being able to physically go and physically do health education through use of this key communication channel. But for all this, it is just clear that in terms of use, health workers, a majority of them had visited or used the cards once a year. So similarly, for the qualitative, that was the same picture when qualitative information was provided. So still, when I look at last time when cards were used by health workers, it is just evident that majority of them had actually used cards beyond 6 months, indicating that in terms of use, actually for cards, use is actually very, very low. So in terms of use of cards, only 16% of health workers actually use cards in health communication purposes. So results for specific objective 2, looking at factors that affect use of cards. I did look at individual factors, health facility factors, and community factors, because mainly we know that there are individual factors that can actually either affect either positively or negatively on use of cards. There are those that actually arise from a health facility, and those that are community-based. And of course, in terms of, I'm going to indicate the key significant results as per the different variables indicated here. So this also indicates that there are also enabling and hindering factors as a result of the factors that we assessed. Some of the enabling factors include affordability and ease access, and of course also in terms of hindering, you have limited resources and power problems, among others. So at multivariate level, I'll only be able to speak about 2 key factors that were found to be significant in terms of affecting use of community audio towers by health workers. So I found out that health workers that had ever managed or participated in managing the cervical cancer case were actually more likely to use cards for health communication purposes. And of course, health facilities that never had plans which include cards as a key resource in engaging with the communities, we are less likely actually to get involved in health communication. So, but of course, in terms of developing of a theory of change, even these other factors that we are found to be significant at bivariant level, we actually incorporated because at a certain point, they are able to contribute to effective health communication service delivery. Similarly, for the qualitative results, the results were similar to what the qualitative results are provided. So sub-study two mainly looks at specific objective 3, and this adopted a design for cluster randomized control trial. Of course, it was quantitative in nature, and the study population were females aged between 21 to 60 years. And it had 2 study arms, the intervention arm and the control arm, and 4 clusters were in each arm. So a cluster composed of a village or villages that receive information from the same CAT. So if a community audio tower serves a number of villages, so those villages formed a cluster. So if a community audio tower serves only one village, so that village formed a cluster. So the study included the females aged between 21 to 60 years, residing in the catchment area for at least 3 months, and that catchment area was in position to be able to receive information from CATs. And of course, also the other key aspect was that those who were recruited had no intention to relocate for the next 6 months. So as I indicated earlier, that this study was looked at to be superior in terms of CATs being superior. So I adopted the superiority community randomized control trial formula to be able to determine the sample size. There are 3 key issues here to look at. Is P1, which was adopted from a study that was conducted from Masaka, which indicated that females who had actually gone for cervical cancer screening in Masaka, in nearby district in Kyotera, were 7%. So because there was no available literature to support number of women, or provide number of women who had actually gone for screening in Kyotera. And then the approximate value of efficacy rate for CATs as a treatment here was proposed to be at 20%, giving P2 as 0.2. And this was also adopted from a study that was conducted in East and Southern Africa, which looked at the highest number of women that can go for screening with rigorous community-based approaches. And actually, this also was able to indicate, to give the percentage difference between 7, that is for Masaka, which is nearby this for Kyotera, and then 20%. So that in this study, the projection was that what would make CATs to be superior, that there must be a difference at baseline of 13% between the baseline and endline. That difference must be 13% to make CATs actually superior. The other key issue is that we know that for superiority trials, a difference of 10% is good enough to indicate that this intervention is actually superior. So this gave me 240 as study participants, and these study participants are supposed to be for each study arm. So since I had 2 study arms, so this gave me actually 480 participants. And because I had 8 clusters, each cluster had 60 participants. For randomization, unit of randomization was a cluster, and in terms of allocation, they were assigned within a ratio of 1:1. That means that each arm had same number of clusters and same number of participants in each of these. And of course, these were randomly, the intervention and control arms were randomly selected, with Kakuto, because Kyotera has 2 health sub-districts, Kakuto being an intervention health sub-district or arm, and then Kyotera being a control health sub-district or control arm. In terms of blinding, this was a single blinded study. So only the principal investigator and the core research team knew about clusters or arms that actually received treatment or not. And the study participants did not know about the allocation. So this summarizes, this is the randomized control trial profile. So it summarizes the randomization, the allocation, as I've talked about, and the follow-up. So those individuals or participants that participated at baseline were followed up to end line. So this describes how many participated at baseline, and then how many were followed up, or how many completed the study. So it is just very clear here that within the intervention arm, 220 participants completed the study, and then within the control arm, 223 participants have completed the study. So in terms of procedures, intervention, and follow-up, so in both arms, for all clusters, routine health communication procedures continued. There was no interruption of messaging for all different forms. And what is key here to note is that the treatment we gave, or the treatment I gave within the intervention arm, was a uniform message written in Uganda, because Uganda is the local language for Kyotera, that was read in the local language by the community audio towers. And the treatment was in a way that messages were given 3 times in a week, every Saturday, Sunday, and Tuesday. And for each of those days, messages were read in the morning and in the evening, between 6:30 to 7 a.m. and at 9:30 to 10 p.m., between that time. So the messages focused mainly on eligibility, risk factors, signs and symptoms, and benefits of screening. So with of course that gives insights on what aspects of prevention that the study looked at. So as I said, participants recruited and interviewed at baseline were followed up after 90 days, because the intervention took a period of 90 days. So within the control arm, no messages were given through cards regarding issues of prevention of cervical cancer. So the usual care or standard care was applied within the control arm. In terms of outcomes, so for this RCT, the primary outcome was proportion of women who had actually screened. So the secondary outcomes were 2. One was intention to get screened. The other one was actually regarding increase in knowledge on prevention of cervical cancer. So what was interesting in the study, and this is an area of assessment of how knowledge was assessed. I did assess knowledge in 3 areas: on eligibility, signs and symptoms, and risk factors. So to the best of my knowledge, I have not been able to find, or I did not find any criteria for assessment of knowledge. And this is one of the avenues or new knowledge created as a result of the PhD study. So the assessment, how knowledge should be assessed regarding cervical cancer prevention. So in terms of data analysis, Stata was also used. 2 key issues here. One, that I adopted a protocol analysis for the randomized control trial. And of course, in terms of determining the efficacy, a multi-level mixed effect linear regression model was used to be able to determine or to get the difference in difference, to be able to tell whether cuts are superior channel of communication. Results. So 2 key issues that are significant here. One of them is in terms of highest level of education. Most of these people, 36% of the entire population studied, had not gone up to primary 7. And of course, most of the participants were young people between 20 to 29, but majority of the people that participate in this study were actually married. So that also signifies the essence of having this study in Kyotera, because of early marriages, and we know that some of these are key risk factors for getting cancer of the cervix. So in terms of efficacy, so the results, summarizing the results at baseline and at endline, what is the key? For purposes of this presentation, I've been able to only highlight significant results as per the outcome, which I indicated. That the primary outcome was having women who have gone for screening. And it is very clear here that within control, at baseline and endline, there was only a difference of 0.08%. And for the intervention, there was a difference of 23.38% as a result of the treatment. And that also speaks the same to other areas on knowledge of risk factors, knowledge on eligibility, and of course, knowledge on signs and symptoms. So I found out that cuts did a good job in increasing health literacy and mobilizing people to go for cervical cancer screening. So this demonstrates how the difference is between the control and intervention arm. So, and of course, for screening, it indicates that the difference between the two arms is actually 23.3%, which is a good sign that CATS can do a good job at the community level. So this is still similar for knowledge on risk factors. That is the same on eligibility. It's the same on signs and symptoms. So the only area that was not significant was actually on intention to screen. So for both arms, there was no significant difference between the control and the intervention arms. So meaning that this is one of the areas that was found not to be significant. So whether the cards are available or not for both arms, so it was found out that there was no big difference. So in terms of contribution of this study or this PhD contribution, there are mainly 4 areas: in terms of policy and strategy, in terms of knowledge, in terms of health promotion practice, and in terms of methodology. In terms of policy, as I indicated, the Ugandan current policy looks at screening to be starting from 25 to 49. So there's a lot of literature indicating that we have people who are found to be positive for cancer of the cervix when they are below 25 years. So similarly, there are people who are found to be positive for cancer of the cervix when they are actually above 49 years. So yet our policy and strategy talks of between 25. So in my study, I looked at a range of 21 to 60, and I think this is one contribution which I think that the Ministry of Health should adopt. The other key issue on strategy is the inclusion criteria for eligibility of people who should go for screening. Our policy is not explicit in terms of who should, yet we know that people who are found to be HIV positive should ideally be going for screening every year. And of course, Kyotera, where I did the study from, the prevalence rate is actually very high. And of course, the other key issue in terms of policy and strategy is on legalization and licensure of cards. Currently, cards are not a recognized communication channel in the country. They have been partly used during the COVID times, but that has been temporary. So it's a temporary authorization. So what I'm bringing out in the study here in terms of strategy and policy is to have cards legalized and licensed as a key resource that can be used at a community level. In terms of knowledge, 2 key issues here, an addition on literature, and also in terms of assessment of cervical cancer knowledge, based on signs and symptoms, risk factors, and eligibility. And of course, the criteria as was provided earlier on. In terms of health promotion practice, it's evident that targeted health communication using community members who are non-health professionals can do a long way in improving health indicators. And of course, we know that currently in the practice, many people are focusing on digital. So our country or many countries across the globe that are developing in terms of internet access, in terms of financial ability to be able to get gadgets or even cells for radios and etc. may not be able actually to get all the key preventive messages. So we need to adopt some of these key targeted approaches. And the other key issue is the use of community-based resources, that is human resource, the non-health professionals. Like in this study, I used the cards and they did give out the messages very well. So we need to rely on them to be able to advance the disease prevention agenda. And in terms of methodology, to the best of my knowledge, this is the first community randomized control trial on use of cards to support health communication efforts within the country, within the region, and I've not also been able to find any community randomized control trial on use of cards, whether it's on health or non-health issues across the globe, at least for the published ones. And the other key issue on the methodology also is assessing knowledge on prevention of cervical cancer. So the criteria that I adopted, I think would be good to be taken on at a global level. And the other key contribution also for the PhD is the theory of change. So I was able to get different constructs and of course also factoring in using the socio-ecological model, the different layers and how they how different layers actually affect use, and also looking at the philosophical grounding for the critical realism that I looked at here, being able to unveil what others cannot be able to observe can actually push a long way. So it looks at the different inputs. Cuts fall under the health communication materials, the activities that we need to do, the key outputs to look at, the intermediate outcomes, and the long-term outcomes. And then also, the table below looks at the different assumptions. So I did have or develop different assumptions, because at a community level, the number of assumptions you must put into play if you are doing planning. So there are three limitations that for this study. Number one, the study did not evaluate health worker knowledge on cervical cancer, yet knowledge can influence health communication practices. The study did not explore health workers' involvement in health communication through other channels rather than cuts. So whereas the study looks at cuts were not able to be used by health workers, so the study was not able to look at whether the actual health workers are looking at using other forms of communication. And also interesting that the other key limitations that we know that the median number of clusters for a cluster randomized control trial should be between 20 to 25. I did use 8 clusters, mainly because if you also look at this study as a pilot study within the operations of cuts, literature indicates that the median should be 4. So the minimum number of cuts adopted for this is 4. And but I take that to one of the limitations of the study, that I was not able to have so many clusters. My conclusion, the conclusion is based on 3 different specific objectives. Conclusion 1, cuts were readily available and accessible for cervical cancer health promotion by health workers. However, utilization was very low despite the availability. The other key issue is that conclusion, health workers ought to use available resources at community level. That these are the cuts in advancing the cervical cancer prevention efforts. And then the other key conclusion and factors affecting use of cuts, that lack of health facility plans that incorporate use of cuts for health promotion purposes affects their utilization. That actually means that health facilities should actually be having plans in place. And then health facilities need to strategically include cuts in facility plans as a mechanism of promoting prevention of cervical cancer among individuals and communities. And then the other key conclusion is that cuts are an efficacious channel of health communication when strategically used for prevention of cervical cancer. My recommendations to Ministry of Health are policies and strategic directions on the use of cuts. I'm saying policies and strategies should include cuts as a key resource for health communication. And then also incorporation of health communication as a key CPD training module for all health workers, as I hinted on when I was giving my bivariant results. At this level, integration of cuts in health promotion operational plans is very instrumental, and involvement of non-health practitioners like cuts as key agents of delivery of health education services. And also this should also endeavor to make regulations or ordinances that govern the use of cuts in communities. UCC, which is mandated to regularize and govern or licensure cuts or any communication channel, they should fast track the permanent authorization of the use of cuts in communities where they are used. And then health workers should routinely use available, acceptable, and close to community resources and networks for increased health literacy. Areas of further research, one looks at health workers' knowledge on cervical cancer and its effect in public health communication. The other key recommendation for further research, we need to have a wide-scale community randomized control trial on effectiveness of cuts. Now that I looked at efficacy, the other study can look at effectiveness going forward of cuts in health communication. Maybe if this panel deems it fit that this work is worth a PhD, that may be one of my key areas of focus for postdoctorate. And then the other key issue is a comparative study on use of cuts in urban and rural areas in health communication. for prevention of cancer. I did look my research based on rural communities. I think it's better to also look at purely urban communities. And then the contribution of non-health practitioners in delivery of health education services for prevention of diseases, and also the influence of communities on health work-led health communication. That is also one of the key areas. So this paper was published this week in the risk management and healthcare policy. And this is for sub-study 1. So the paper is available. And I would say that this is the first study that looks at use of cats in health, to the best of my knowledge, across the globe. And I have another paper that has been accepted in the Journal of Community Medicine and Public Health. That's for the sub-study 2. I looked at uptake, knowledge, and perception of cervical cancer screening among rural women in Kyotera district. So I do thank Uganda Matters University for the opportunity given to me to make this presentation, but of course also for the previous 4 years to undertake this Doctor of Philosophy in Public Health. Professor Eva Manpo, my advisor, all study participants, a number of colleagues that have contributed to this work, the reviewers and examiners who are here, and my family, especially my wife who is here, for their patience for all this period. Thank you very much.
Give it up for the presentation. Now the examiners will go back to their seats at the front table, and we begin to ask you for more detail on a number of things.
Thank you very much for that elaborate presentation. And the work we've done that is accompanied by publications that give credibility and added value to your research. Thank you very much. Now I would like to invite Professor Tomene to interrogate you. You'll be given an opportunity to respond as we go. Professor,
Are you finding
I sit the other side? Yes, I think.
somewhere where we can have a conversation?
the microphone.
I hope there is another camera that will give it in the scene. Yeah. But you need a paper to cover, right? Other UMS staff who are here, fellow examiners, ladies and gentlemen, welcome to observe. Greetings first from my career, where I am just been appointed Professor Emeritus and Kabanda University. Thank you very much, Dr. Sister Elizabeth, for appointing me with them. It was quite a task that I completed during the terrible wave of COVID-19 that claimed over 15 doctors, colleagues of mine, some of my former students and friends. So I hope, I really hope, that you understood my reluctance but stayed in a face-to-face engagement. Nonetheless, I'm so glad, sister, you liked and limited the numbers. Much appreciated. Now over to Richard. Thank you, Richard, for sharing your very important work. It was a pleasure reading it, and it is even I appreciate this with you. It was largely refreshing, and it must have taken a lot of time. And Madam Kabanda, PhDs take a lot of time. Please, thank you for supporting me. So, Richard, congratulations so far. I want to take a helicopter journey through your discussion so that we can reach a common ground. So please feel at home. So the first interaction. Since you are communicating in simple language, tell these ladies and gentlemen, in simple language, what problem was the work trying to do? In simple language. What was the problem? This was trying to address.
The thesis was trying to address issues related to low cervical cancer literacy, despite the fact that you have community-based resources you can leverage on to engage members of the community.
So if you are trying to address low cervical cancer, not getting it. So low cervical cancer.
Can you please leave the microphone with Leave the microphone.
Low cervical, not getting it. Low cervical cancer,
So we have low cervical cancer literacy, despite availability of community-based communication channels that we can leverage on to get
Thank you very much. It wasn't clear in the thesis when I read it, and I read it many times. And I was trying to identify this Kabanda, what is he trying to do? What is he studying? I went to the conceptual framework, I did not find that easy. Because when you conceptualize work, you must identify the problem so that even the person here, because he was never going to speak, understands what you're trying to do. But we shall come back a little bit later. I will now go to the title. To what extent does your title reflect the contents of your thesis? To what extent does your title reflect the contents of your thesis? Have you thought about it?
I don't know if I got you right, Professor.
You don't get me with it.
whether I got right your question.
Okay, let me repeat it. You have studied several things. One is the availability and use. The second one is what factors affect use. And the third one is the efficacy. Okay, I have all of it in my head. When you read your title, does it reflect those three things that I have said? That's what I wanted to do.
Yes, I believe so.
Okay, I have it here. I'm going to read it for you. Use of community audio towers in health communication for prevention of cervical cancer in Uganda and rural communities. How does that reflect the three core areas we are studying? When I read that title, it is out of sync with what you are studying. You are looking at use of community, and that's it. Use of community and audio towers in health communication for prevention of cervical cancer in Uganda and rural communities. Does this title really reflect the three things you have said?
Professor, if you look at the three key things, and of course also guided by the critical realism thinking, I was able to unveil for you, and if you look at use of cards or community audio towers, you need to go into deeper details of the wide use of cards. So what should come into your mind when you think about use of cards? That what are these cards? Are they available to people who are supposed to use them? How do they use them? What are those key issues that actually support them to use them? Or what are some of those key issues that hinder them to use these cards effectively? Then the other major key question, which is actually the core of this study, is that, but are these, can the cards do a good job in passing or reaching out to members of the community where they serve, the geographic origin? And that is why I looked at efficacy, because I did not find any study within the country or region or across the globe that looks at either the efficaciousness of cards or effectiveness of cards. So for me, if you go into the unobserved details of the use, the three things actually point to the use of cards. And of course, the use of cards is within the area of health communication. And of course, we know that health communication is the core of prevention of diseases. So if you narrow it down to cervical cancer, that's why you need all the three components. And we know.
Okay, thank you. Let's just proceed. I think that the communicators, because I think you've done yourself in studies, not putting certain things in the title. When people want looking it up and want to read it, for example, if I want to know about the RCT, the efficacy, I read your work because it doesn't reflect what is in your work, and yet it's a big chunk of your work. So I read the Yes, please.
Yes, thank you very much, Professor, for this very good observations. Would you not mind accepting that you can make an adjustment in the title now that we have appointed to make the argument shorter? That if there is a view that the content is extensive, that there will be need to make an adjustment to the topic if suggested by the examiners, you should then be able to comply with. Is that okay with you?
Given that guidance, Professor, of course, I think it's an area that I'm going to look into and include.
Thank you, Richard. Then you have a general objective, which is to promote the use of locally available community health promotion resources, health communication, of prevention of cervical cancer in Uganda rural communities. I'm quoting you, Robert, over there in your book. Was this objective achievable? No, the manager, waiting when
No, please.
we ran from them.
No, please.
The professor, the experts. You know, the objective should be achievable. Now, the objective are reached. I said, how could the government achieve this objective? And I reached the conclusion that maybe you didn't achieve it, but we shall look at that a little more. And maybe let me ask here, why you have put in Ugandan rural communities. Your study was in Kaputo, Kyotera, and part of Kyotera is Kaputo. That's why your study was. And looking at your methodology, you did not give priority for Amudas or Kamuri a chance to be represented in your study. Yet you are saying categorically that you are doing it in Ugandan rural communities. It's Kyotera equal to Uganda.
Thank you, Prof. I indicated in the title that case of Kyotera, because I was not able to look at all the communities. But I think I made it to focus that also to be specific, based on the guidance that I took from this panel, not to generalize it. So the panel thinks that the focus is to look at Kyotera, to give the title and the context. So it's really more focused. Then that adjustment will be made.
Then just on Professor Field, the issue is not for you to debate from your study all the time, but the issue is for you to observe whether our comments are relevant to your study. Could you possibly accept this as an invitation to your study and say probably this may not be generalizable, and you have an argument to make as a professional and a researcher, other than attempting then to want to go and do the whole country and come back and ask to do the neighboring country?
Thank you, Richard. And of course, now you are going to be a teacher. That's what PhD means. You are running, we are running. But also you are going to be a supervisor. You will be teaching them that in research, we have what we call generalizability, and we call that external validity. You have a chance to do that. Now, the control, the answer. I'm sure I have but we can discuss it. The randomized control trial is, as you know, the gold standard for research. And I congratulate you for attempting. But the randomized control trial must have a hypothesis. It's not just what you're thinking, and it should be teased out itself, away from the other two studies, the other two objectives, and you get a hypothesis. And with very clear outcome variables. And congratulations, you have actually clear outcome variables in it. Basically, screening for cancer, intention screen, and knowledge about cancer. I wanted to know why you restricted yourself and put a lot of emphasis on knowledge about cancer. Yet that was the secondary objective. The primary objective was screening for cancer and intention to screen. But in the secondary, this one was really, maybe that's where the interest is. When you respond why you put so much emphasis on knowledge and did not talk very much about screening for cancer and intention to screen.
Thank you, Professor. The primary outcome of screening for cancer was clearly indicated in the results. Because it has a standard procedure that is already defined, documented. So the missing link for those three outcome measures was of knowledge, because you can educate me more, but I did not find any standard criteria for measuring knowledge for cervical cancer. And that's why when I was developing the outcome variables, so that was the variable that is required to give it more thought. So in methodology, giving it more thought, but of course also in terms of composition. So the issue regarding cervical cancer screening was able to demonstrate the efficaciousness of cats. And when that was realized in the results, I assumed that that was good enough to indicate how cats are efficacious in nature to use them to communicate.
But in the other CT, you determine the outcomes. I think Professor Barber knows this more. Embryonic, you determine the outcomes before you do the study. So if you thought knowledge was the leading thing, I think it would have been very good for you to make knowledge as a primary outcome. And let me explain to you what that means. Primary outcome in RCT is the outcome for which you have adequate sample size. So you haven't decided, because now you can't do it, but I think it's a limitation. You should have made that knowledge primary of this. This morning I saw that you had published that paper. I really want to congratulate you. I don't know whether it's indexed or not. It's a company, so I don't know. Is this paper indexed on Medline? PubMed?
Yes, both.
Congratulations. I really want to congratulate you. And this paper adopted cross-sectional study design. Can you tell us what are the disadvantages of cross-sectional study design?
I think, Professor, since I did study that at a point in time, chances are high that results can change in time. And at times it may not be good to make conclusions based on that fact.
Yeah, so if you have a goal, and I want to know whether smoking leads to a goal, you cannot just kill at the same time, because you may have stopped the smoking because you have a goal. So the exposure and outcome are measured at the same time. That's really the answer. Your thesis can be classified as utilizing mixed methods approach, isn't it?
Yes, Prof.
To what extent do you think you succeeded in blending the quantitative and the qualitative approaches? You put some quotations. Have you succeeded in blending the results? And if you have, give me examples.
I would suggest both, because this was a new area, and maybe I wanted to know if the results I get from qualitative are either similar or not similar to the results I get from quantitative. But having both of these two done differently. But at the time of interpretation of results, of course, the major issue there was that if you look at the probing areas for the quantitative, we are more or less similar to the areas of focus for the quantitative.
So you clearly identify the themes which emerge out of the qualitative work and link them with your quantitative work. That's how I was asking you this. And what did you understand by protocol analysis in randomized control trials? You've used that term, protocol analysis. What did you understand?
Protocol analysis means that you are only analyzing those participants who are able to complete the study period. So
in a good RCT, we do not do a protocol analysis. We do intention to treat analysis. And that takes me to your numbers. 480 were randomized and 443 completed. And you have the power of 80. Now, when your numbers drop, what happens to your power?
scientifically, the power can easily drop. But remember, intention to treat, you can educate him about this study was looking at the efficacy of cats. And the beauty with the protocol, you are able to know the effect of the treatment and its impact on the population that you subject it to. So you can only be able to tell its effect if you analyze it or have been able to go through up to the end.
That will be good for you as Richard. I have a pharmacist next to me. If you do a protocol analysis, people will start wondering, why did they only analyze those who did well and those who came? So the reason why we didn't intention to treat, we assign the worst outcome to those who dropped out. Let me just continue. Why did you study only 4 clusters? Yet you told us it should be between 20 and 25. Why did you study only 4? You see, when you do not do work according to the standard, if the recommended is 20 to 24, and you studied 4 in each area, meaning you have studied 8. These people cannot replicate your study because they can't replicate it because of the very low numbers of clusters. And that's really, for me, I said, this RCT, I love RCT, I do RCTs, but I'm not having enough clusters. So it's you can't change it. I think it's a major limitation, and I'm so glad you have mentioned it. Theory of change, let me wait for that theory. You have developed an interesting model, and the theory of change was survival prevention presentations. You've attempted to make it clear, but in the book, I basically do not understand. It's too crowded, it has too many things you're studying, and I think you need to simplify it. And I'm not a communicator, but I think the communicators might still use it if something is simple in place. So I had a challenge with it, yeah. I wanted to talk about generalizability again, and that's key. You say that they are efficacious, these cards, they are efficacious for prevention, for etc., for cervical cancer. And you go ahead, and congratulations, by the way, for being the commissioner. I was looking you up. Congratulations to you for being the commissioner in health. Because then your work is going to influence. And now you are recommending cards for COVID-19, for diabetes. What is the basis of this recommendation? You have already studied COVID-19, cards cervical cancer. How can you generalize something from cervical cancer and put it to other diseases? I think found it. Yeah, so maybe you can explain why you are generalizing.
I think, Professor, for academic purposes, the main focus that recommendation to cervical cancer. But the idea behind that was that the practice, if you look at also the trend of prevention of cervical cancer, the behavior and the practice-related issues that we expect to get from communities. I thought that communities are faced with so many health challenges, and having this was like a benchmark that the same principles and processes that I went through, be able to identify that cancer is infectious, can still be applied to address other health issues at the community level. Because it may be difficult to do disease-specific studies all through. That was the state.
Okay, so Richard, if you got enough resources, you had all the money in the world to repeat this study, what would you do differently?
Two key areas. I did this study in a homogeneous kind of community. And since mainly since I was looking at efficacy, Prof, you know that for an efficacy study, related study like that, that would be better at the start in the homogeneous kind of community. So, but given resources, I will look at other, that's why I gave a recommendation, being able to have it done in a number of clusters, having many clusters, and of course also look at other parts beyond rural communities, so that we will look at other, and of course even communities that have other social cultural kind of differences, be able to have good recommendations and conclusions.
Okay, thank you, Richard. I hope you have found the discussion useful.
Thank you.
And I've made my comments. I did a lot of extensive editing of your work. I did want to ask you about it. It's available to you.
Thank you very much, Professor Tumuime, for those highlights and for comments. I'm going to guide Richard to his work. I would like to invite Professor Kaiwa to give us his observations.
Thank you very much. Dr. Sister, the sister of sound. That's forgotten. There was a major seminary for many years. And you know, God is very many, but chooses few. I am now being called to serve in other capacities. And it's a pleasure. Thanks very much for the invitation to Uganda Matters University. This is our university. I think at some point I might want to do my last tour of Italy. No, not the last, but we need a tour of Italy in our university. I want to congratulate you for coming this far and add my voice to thank Madam for enjoying the cold nights when we were waking up at 3 a.m. Did you?
Very tired.
All the time. A good idea comes at 3 a.m. and you have to wake up and put that idea on paper. By the way, for the benefit of everyone, and I will briefly remove from the first. so that you see the person behind you. The gray-haired man. But when you meet me somewhere, don't bypass me. So, as Dr. Moses said, I'm a specialist in communication. So, you've been engaged by these specialists in health communication. And our attempt to give us, by the way, done a lot of work for us in communication. A couple of questions it poses to you related to communication. And I want to thank you for two things. One, the rain this morning in African culture, that means a lot. Two, for doing a study that is at the intersection of communication and health. So I want to thank you, I want to thank the supervisor and the doctoral committee who do amazing work behind doors. I am glad that you are making, proposing quite some interesting contributions. The four of them that we put up here in the book, you know, five. You might want to see probably there is an over there with in there. Now, I edited, I worked in the New Vision, worked in the Monitor for many years, I've edited many books. And usually when I'm doing the PhD reading, PhD books and masters and so on, I desist from doing editing for you. So, Professor, but I make the comments, of course, in the text you see them. I know one thing that we go through the the thing. Towards the end, we see that you are really fatigued. But you know, the two decades of this world, what makes them winners is that resilience in the last lap. So you might want in the revision that we are going to propose, you know, to do a bit of more teasing out of certain things in those kind of chapters. Now, however, I want to make my intervention starting with, first of all, your conceptual framework. Professor Mwine alluded that he talked about, and I want you again to at this point in time, the most defenses for a lot of your books, is it the case? You can have you can have his book, right? Do you have your book? Madam, okay. And the discovery they don't have the book as well.
I can access it.
No, I would have wanted, no problem. You will take note of the comments I made. So, what are the conceptual framework on the I think it becomes easier if you help us figure out what you know, you name the variables. What are the variables? What are the variables? You have other types of variables, antecedent variables, and so on and so on. It is not this must with us in space variable. You don't wear space, but for me now, it's very random. So I have just my space, common so that I can be able to look at it. So, concept of framework, delineate the variables for us, the dependent ones, the independent, and so on and so on. Two, we were playing these three concepts, and I thank you really for your section on the, you know, the concepts and defining them. But you seem to play three concepts interchangeably. You seem to think communication, knowledge, and literacy almost mean the same thing. And sometimes I see you use the terms interchangeably. So you might want to look at that as well, so that you don't continue that direction. My first question, other than, you know, in these defenses, we do two things. So the question Professor Kumini was asking you was for you to educate us and the people out there. Because this is an incredible contribution you are making to knowledge. I hope by the end of this session, you change status. It's my prayer that you are changing status. You are becoming a doctor or philosophy in that particular field. So here we get you to know one, are you the one who did the one? Two, to also celebrate you, celebrate the work we did. So I'm glad that your communication was very good, your oral communication was very good, your oral presentation, and I want you to, relax and enjoy the moment. It's an examination, but I also think a PhD examination is an opportunity for you to bring home. Maybe that's the tradition from my Canadian training, which was by the time you train, it is a celebration. You are educated. That's what I want to do. But in fact, it's funny, some questions. Question one is on the theory. Yes, you are going to come to the in this particular field. And it started off by the perspective. You see, the study is done by tradition or perspective. So I need the audience out there, people out there, can you educate us on which other traditions you think, or any other tradition that we could have used? How is this tradition different from that as those other traditions? Very good.
Doctor, you have talked about two areas, one on philosophical and one on theoretical.
No, I'm not the series of Let's start with the tradition and philosophical perspectives. If you have your book, we don't have a problem, we have referred to your book, but then these things, so the post-positivism philosophical perspective. I'm sure we know that from other perspectives. So I want you to educate the public out there, the people who are listening us, what are these philosophical perspectives? Which other philosophical perspectives exist out there? And why did you among those choose this question? I happen to have done it from my major seminary background, so that's why this is the important question.
So mainly they are four main areas.
Philosophical perspective. Empiricism, critical, normative, and so on. Just ease your mind a bit so that you remember. I know you probably read this a long time ago. But if you have, there is no harm. You just say, that has stuck to my mind, and then we move on. Yes.
I only have yes, at that point in time, deciding which philosophical perspective of grounding should guide this study. I did not find any competing views apart from the positivism. Mainly because of two key reasons. Number one, that I had wanted this study, of course, based on the specific objectives. It was taking me to use methods approach. We're going to come to that as well. And the other aspect was also that I also wanted to unveil insight means some of the unknowns beyond what people are able to see or observe. So that really drove me to the positive zone.
Thank you very much. Let's go to your theory. The social ecological model, I believe it's a very relevant theory. But I also want to commend you for proposing a few competing theories, a few competing ones. So basically, that's what I wanted to get to also refer to in your previous question, the philosophical perspective. Now, I'm from communication, mass communication is a communication, but a different it's language. Means mass communication. I wonder why in the competing one, we have in mass communication what we call participatory communication. Ever heard of it? Participatory communication proposed by Jan Savi. Written books about it. If you go to the library, I can go here. Because you must come across books titled exactly by participatory communication. So that's a competing theoretical framework that I think would have been very relevant for this kind of study. So I encourage you because you are going to make revisions. We already don't worry, we already undertake them with grace. So that is one that I wanted to do. And you have deliberately with the supervisor to say, we have considered this and we don't think it is the very. But for us in our field, if I'm reading your book and it is communication, you are claiming it is communication, and I don't see you acknowledge not just communication, but facts, community, all your doubts. So the participatory communication theory is very important. Two, the knowledge gap theory. Knowledge gap theory developed by John Kyotera and taken on. Because you're playing, it's very clear we see you and Professor Mine that was talking about knowledge, but you are talking about efficacy as well. So this is a very, very important theoretical framework to look at. Okay, now my second last question, because some of us are continuing, we are talking from this side towards the other side, including a supervisor in the field. On method, convergent mixed methods. There are several that the author that you cited, Cross-Sectional, proposes several methods that we could have used within that. Again, I want you to tell us in the sequential, explanatory, sequential, exploratory, sequential, transformative, combined. Remember those ones. Again, I want you to educate the people listening to us. Why did you choose this particular approach as opposed to the many others, probably 8 of them, that you could have chosen? You could educate about why you chose this one. In other words, what are the key characteristics for the convergent mixing methods? So the people listening who have been read your book, for us we read it, we know, but the people who are listening.
Thank you, Doctor. I adopted the concurrent one, mainly because in principle, you know that you do collect qualitative data independently. You also collect quantitative and qualitative independently. You also analyze both qualitative and quantitative independently. And you only manage at interpretation stage. The reason why I adopted this that I never wanted to be biased by either of the other. Because with explanatory, questions start with the quantitative. And many times, many researchers, the results that you have got from the quantitative process sometimes guide the way you ask and the way you go. So I wanted to understand and get the true picture about use of cats without being biased by either of the other. That's the essence of this.
Yes, thanks very much. Now, my second lesson, so that we can pass on to the other colleagues. You will see very many comments within this. Okay, very many comments, and at the end of every chapter, I have comments. Typical lecturer style, your lecturer in red. I could have used the blue, but for effect, you use red. So you will attend to those, and then of course the reports that you will receive. So in the interest of time, I want to take you to the field of change. And I think, Mr. Kabanda, the field of change, you put it up there on page, and Professor Tumina alluded to Professor, and I thought I would do it with you. In my view, this is one of your most outstanding contributions to this study. It is something that is, is going to put you out there. And I think you've not done justice to that field of change. And the reasons are probably true, but the main one is because, first of all, you did not do justice to your conceptual framework. We don't see you come back to that conceptual framework, mainly because of the fact that you did not delineate the variables in the conceptual framework. So the field of change, page 169, you could have helped us to break down the response better. The results are very difficult to read. In fact, I had to ask Dr. Namas to send to me a soft copy so that I can be able to play around with it and be able to read it and understand it. But this note is not very strange. Okay? You put it there, you really don't do justice to that field of change. I wish you could go back to, I want to take you back to that field of change, so that you tell us, in your defense, you put it up and you explain it. But I want to summarize it for us without looking at the thing, something coming out of your head and your heart, because this is the gist of your contribution. Over to you.
Thank you, Doctor. I know that Professor Tumino used to read it, and for purposes of this presentation, I actually unpacked the field of change. I think what I was saying is better than what is in the book.
Absolutely.
And I had thought earlier that the write-up in the book required more details. Required more details. That's why I think it looks to be packed.
The graphic is the infographic is fine, but I'm not talking about even that. I'm talking about that, number one, but two, the description, the narrative in that part is also lacking. But why?
Yeah, so what I'm going to do in the final write-up is to make sure that I unpack it the way you have presented it. And also make more write-up despite the different areas, so that it becomes easier for the reader to follow.
Okay, I really want to thank you very much, Mr. Kabanda. Again, I say most of the comments, within the book, but also in the report that I provided to the university. I want to invite you in defining this chapter to make sure that you cross-tabulate the social demographics. The social demographics that present on page 98. They are very important. So you don't put there things that you're not going to use later. What are they for? You have very nice things here. Page 98, the distribution of exponents by professional qualification. Okay? The paragraph definition, orders, and so on and so on. But then in the analysis, we don't see you make use of those fellows, especially for circulating them with variables taken from your conceptual framework. So if you will do that, I think that would be a wonderful job. So really, Mr. Kabanda, I want to thank you. I made comments about the title professor. I agree with you that the title you can return. Make it more. So you return the title so that it becomes very effective. I congratulate you for the bringing this dissertation from the perspective of the work you do, and I encourage you to bring it before you are throwing it as if it is part of the research. I don't think it is. Bring it forward as a global, so that we know that okay, this is situated. And there is no harm in us as researchers being situated individuals in the work we do. So, Mr. Kabanda, it is congratulations from me. It is congratulations to Uganda University and the supervisor, and of course my colleagues who have taken the time to do this one. Thank you very much and God bless.
Thank you very much, Professor Ayebwa.
I welcome the promotion. Well, I profess,
Allow me to invite Professor Rolla to give us to interrogate the candidate. Professor Rolla. Thank you very much. I have to say that I'm not a specialist in health, so I cannot comment on your health issues. And there are professionals here whose work it is to do that. But as a non-health person, specialist, I enjoyed reading the work written. I learned a lot from reading what is in there. Now I know that there are things that are possible because you brought them to the fore. Thank you very much for that contribution. Now, for me, one of the things that struck me was one of the recommendations. Of course, I started thinking about it from the beginning. When you started talking about cuts and availability and the use, I said, that sounds good. Now, the problem is, as I went through it, I began to feel that there was something missing somewhere, perhaps because of my ignorance. Now, this cut, I grew up in the eastern region, desert specifically. But I've never heard of that. I've never seen any object that you describe in your work. So it becomes a problem when you study perhaps an area where there is something, and then you say in one of your recommendations that perhaps the Ministry of Health
could actually use, promote these cats. But they don't seem to exist in my part of the world, and I'm sure there are also other parts of Uganda where cats do not exist at all. But it's not very easy perhaps it is not quite true or useful to advocate for the use of cats across the country when they don't exist at all. So I don't know how aware you are of that fact. For me, I'm not aware. Perhaps you could comment on that first.
Thank you, Professor. Yes, I agree with you that in some parts of the country, we don't have community audio towers, but we have community audio towers available in a number of areas across the country. Most significant, especially within Central and East Central. And the concept of engaging and working with the communities largely depends on resources that are available in that community. So when the ministry, for example, under that recommendation, when the ministry promotes the use of cats, doesn't necessarily mean that in the communities where they are going to be used, they should be put onto the people. But in the communities where they are used and acceptable, and members of that community believe that they work, actually cats should be promoted. It's the same thing when you have kingdoms in some parts of the country and other parts of the country, you say, cultural leaders. So it doesn't take away the gesture of the community that has that kind of resource to use it for purposes of improving or promoting their health. So that was the gesture.
Now that you are a commissioner, I believe that's what you are, the Minister of Health, am I correct? You are making recommendations for the Minister of Health. So what are you going to do about the rest of the country that does not know these kinds of things?
So as I described, this is a resource that is owned by the community. So the beginning part is for the ministry to indicate that this is a key resource that can actually be used to engage and promote health through health communication avenues. And I think what can easily happen is that if there are areas where cats have demonstrated that they are overvalued, then chances are high that the ministry can actually be able to engage members of the communities in other parts of the country that don't have the let them know that we have this resource that can be used to advance not only within health, but a number of social issues in the community. And once members of that community actually feel that this can actually apply in their area, then I think that's something that can easily be taken out.
Thank you very much. It would probably be, I'm not sure whether you'd like to accept this, but you could probably mention that this non-existence of these instruments is actually a limitation, which you could mention in your work. You didn't mention it anyway. I don't remember.
Let me think about it, Professor. And see if,
well, that's fine. The other thing which I wanted to have you explain to us is the issue of your instruments. I'm thinking particularly about the translated pieces of work which you used for, I think it was questionnaires specifically. Who did your translation? That is one question. The second question related to that is, how sure are you that what was translated is actually what it was in the original piece? You know, many of the terms for medical issues are actually in English. I don't know how much Uganda has got to the medical area. So I'm imagining that somebody will have had to translate from English medical terms to Uganda. Now, one of the problems that I know of is that some translators do a literal translation, and often the meaning is actually lost. So I don't know what it is in your experience when you are trying to do this? Maybe you can throw some light on that.
Professor, I did follow the back-to-back translation process. And yes, it's true, I used an expert to do the translations and from English to Uganda. So, but I was also able to get another independent person to translate again the Uganda version back to English. So then I did compare whether the translated Uganda to English version is similar to the English version that I had earlier. So it's true that there are some differences which we are able to, which we addressed, which I have a copy that was actually tested in the nearby district called Uganda.
Thank you. Well, it's good that you did make an effort to ensure that we have the right information. My next concern is let me start with the compliment, because you definitely seem to have a high competence in English. Your work is really good in terms of your competence. Because I've read some dissertations where you spend all your time just translating, trying to make sense of what the person is trying to say. So yours does not suffer from that problem. The only problem I notice is that you have extremely long and complicated sentences. Now, what has happened as a result is that you end up with what we call split sentence. So you start a sentence and you have to keep going, you lose where you started and you stop somewhere. Then the part which should have been with that part begins a new sentence and the two are not together. So now you want your work to be read by people who are going to be users of the material. Don't you think that maybe you ought to work on some of that material so that it is readable to the ordinary English speaker? Because you need accuracy, you need people to be able to get the message you're trying to say. Yeah, comment.
I agree with you, Professor. After submission, I think 3 months after submission, I read my work again and I saw some areas that we are wanting. And the copy that I have now was subjected to editing services. It was edited by an internet expert. So what will happen is that after getting the comments, supervising them, the final copy still will be given an independent person to do editing to ensure that I have a better copy that will be on the shelf.
Thank you very much, Richard. That is really all I wanted to say to you. But I have to thank you for the great work you did, and I think that definitely it is something that we are pleased to have in our service.
Thank you very much, Professor Ronald. And now I would like to move and request Professor John Charles Okiya to the gate. He's an interdisciplinary. That's the reason I wanted him to come last. Professor, you're welcome.
Thank you very much, Dr. I think, Richard, you can first relax. Stand down. Stretch yourself. Yes, relax. You don't need to stand straight, you can walk around. You feel at home. The one interrogation is a very tough one. It's not what it is. Special thanks to Uganda Mothers University for always trusting in me to do observation of graduate students. Special thanks to Professor Manipo who was my mentor at one time, and the Richard, and the student, a colleague, and his family, Madam. This is a family of Uganda Mothers University. The only thing which is here is difference in it is we are all colleagues. I don't know why the chairperson said it would me to be the last person. Now that I'm beginning to be the last person, we are going to go to the last part of the report. Because I think all the other parts have been interrogated. And I want to thank Richard for first of all encourage undertaking PT. And even just the right reference of that meeting, that goal, even if it was nonsense, that was an achievement. Congratulations. It's not the way we sit down, assemble sentences to pay 300. And the many of the people out there will probably not even start the process. So I want to thank you for the zeal that you've been aware of what I like I said, that since I'm the last person, I'll go to the last part of this. In all PhD studies, I think the most concern academicians want to hear is the new knowledge generated. Everybody wants to hear what is the new knowledge generated. Because apparently, all other works follow all other protocols, like of a master and whatever. But the point of separation is what is the new knowledge. So just to begin with, in your view, having done very extensive research and having looked at several theories, applicable, not applicable, identifying the gaps, what do you think is the new knowledge? You can answer that. What do you think? That you can go from here and say, this is Richard's contribution to the board of knowledge.
Thank you, Professor. I do try to believe that the board of knowledge has been extensively discussed under the contribution of the PhD within different areas. One key area that I hinted on earlier is within the area of knowledge assessment, because I have not come across any paper that is published, the best of my knowledge, that highlights how to assess knowledge on cervical cancer prevention. That is something that was developed, and that is something that has been proposed to be undertaken on. It's not complex, but it's segregation out of this PhD work. The other key issue is that currently many people think about utilization of communication, and there would be traditional forms of engagement in communities tend to be overlooked. So my key area of focus under the current era is to bring on board forms of communication that can synergize disease prevention efforts, which people tend to overlook, and that is the issue or the tool of the community of the towers. So, in terms of contribution, as I indicated in my presentation, I have not come across any study that has actually looked at cats in health. Within Uganda, we only have 2 studies published on the use of cats by Dr. Brian from Makerere, and they are more on general communication.
I appreciate now the issue that we are raising. I appreciate the paucity, the limited information available. You know that PhD research is the depth of the matter. How deep you dive. And in some institutions, they have to promote you, promote you and encourage you to put an objective. The last one, that relates to generation of set of strategies or a model or a theory, so that you do not forget at the end of your research. Otherwise, you will end up doing a master's degree. Now, the question now I'm saying, you have done the analysis of all this. What is critical is how much of cut can change how much of acting. And you get what I'm saying? The model that relates for us to appreciate scientific, that this level of utilization of cut can lead to this level of change in cancer, screening, whatever outcome you put. I get the point. So in the modeling, the recommendations, many of them are there. But we want to demonstrate how much of this should be able to be done. Otherwise, if we end up saying cut encourages this, we have done the masters. But we want you to model out, to tell us how much of the use of this leads to this. Because some of the relationships, for me, the health economists, might not be cost effective for government to adopt something which change of output or outcome is less than 2%. And the cost involved in it is the millions of money. So we need to understand that at the level of generation of knowledge, you are modeling out the parameters that you've been studying along, and how these parameters then yield the final outcome. How much of the change in them creates the change in the desired outcome. So this is very, very critical when you are looking at you are going. Now, the question is, when you are creating the knowledge, there are considerations that you must bear in mind. One is the feasibility of the intervention. How feasible is the intervention? You can relate that with how does this link well with the current position in the health sector? Because for you to generate knowledge that should be adopted, people ask you, this might not be doable. How feasible? And how does this intervention be relate to the current status of service delivery? You may answer that.
Thank you, Professor. What was touched under the key issue regarding computational powers, as I indicated, especially on the characteristics of cuts, that they are owned by the community, serviced by the community. So the Ministry of Health promoting use of cuts is in the spirit of promoting communities to own up and being responsible for their own health in the perspective of utilizing resources that are that without actually government incurring costs. If you look at all these other forms of engagement or tools or channels that we use to engage people, government incurs cost. This kind of tool was communities actually feel as a key resource or tool. Government doesn't necessarily need actually to buy. Government doesn't necessarily need to pay cost somebody who is operating it. Government doesn't necessarily need to put in the cost.
Okay. So what I'm raising in your book is to clearly be able to explain for any model, for any set of intervention, you should clearly be able to explain the feasibilityness of the set of strategies that you have, the applicability of the strategies that you have put. Because we are concerned, you may have a wide idea that cannot be fitting with the current system. So you should be able to explain to us in your book how feasible are these set of patterns. Because as we talk now, they are not clear and good outcome. And then also describe its model also. I know people at PhDs were supposed to create theories, but at least model out a relationship between the outcome variable and the exposures, and show at that level of the multivariate analysis that there could be a significant change in relationship to this extent. Somebody can help you to do the model. Now, the other aspect of it is that you should also highlight the theoretical implications. Theoretical implications that arise from the set of strategies of model. This must be clear because this is actually the PhD part. This is the PhD. What are the theoretical and the practical implications that you are having if this model has to be put in place? And above all, what assumptions have you taken care of? Because this model is not going to operate in the sky. What are the critical assumptions that these strategies that you are implementing, the assumptions that underlie this? You are saying, assuming that resources are available for this, assuming so, there must be something to show us that you consider that it's not going to be an ideal thing, but it's going to be under a set of criteria and conditions. Now, like I said, that mine is going to be the last part. One of the requirements, and sometimes in the PhD, is that we expect the learner, but not always a must, to test the model. You will be expected to test the model. But you can also, at this moment, if you are not having the ability to test because of resource constraint, demonstrate to us which approach this model can use, which approach can use to test this model. There are the approaches for testing the model that we are highlighting. So like other professors highlighted, what you're showing here is much better than what is there. What is missing is how these relationships affect each other. And what are the confounders of these relationships? Once you have this in your chapter, and some universities can insist that new knowledge to the chapter is all, and you really put out that you have created knowledge for a PhD. And so we want to read how you description of your model, assumptions of the model, the benchmark models that you have, or assumptions of set of intervention that you are prescribing. How have you related? How have they related with existing strategies? Because you can be having with repeating strategies that are already existing or working or they have never worked. So you are saying that this model, this set of strategies, is benchmarked from this and this and this that allow this, however, for the specific nature of cancer screening, the additional aspect of this has been engaged and involved. So those are the aspects that we want to look at, to listen in your final chapter of the new knowledge. And once the new knowledge is explainable, you have explained the model, you have told us the benchmarks, you have described the assumptions, you have given us the theoretical implications of the model. You have showed us feasibilityness, how this model will fit into the health sector without having a lot of constraints. You have done vision. So we need an improvement in that area to be able to address this. I didn't want to push a lot of questions, but these are areas that we should be able to strengthen our report. Lastly, I think there was a small thing that was raised regarding the theoretical frameworks and I think the conceptual frameworks. I don't want to traumatize you by repeating them. Because you get traumatized because they are the same. Most senior people have said it. But I think also what is critical in the theoretical reviews that you have is to do the meta-analysis. Yes, to show the failure of the referred models to explain your study. I get your point. Yes, otherwise, then why are you doing a study if there are models in existence that are explaining a phenomenon? So you're saying that these models explain all this, however, they fail to explain. You must get the reason of failure. I get the point. Yes. Dr. Lisa, are you listening? You must show us the failure that this is a good model. It is being very backed, but the shortcoming of this model is applicable. Let it be applicable among the HSO, not among the Baganda. Show us. I get the point. Yes. So otherwise, benchmarking what is the relevant, related models and theories is good. But what we're interested in, for you to show at the meta-analysis the failure of the model or the theory to explain the current status that you're studying. Therefore, the setting you're studying. Chair, my inputs on the final aspect of knowledge generation. I thank you for giving me this opportunity. I thank Richard Kabanda for the very, very vigorous process you have gone through. PhD works have processes that if you reach here, you are nearer to the goal. So you have not to have any backlog. Because where you are, we are talking about looking at what you've already done. There are some people who have nothing to show us to be commenting on. If you are lucky, you are being focused on what you've done. Thank you very much.
Thank you very much, Professor Kiria. Thank you very much, the panel. And now, at this point in time, I want to thank Richard very much and invite the panel who will withdraw for the deliberations, and then we'll come back to communicate together. Thank you.
Now is the time for the rosary.
Inspired by God, by whose name we are called, the martyrs of Uganda, source for our courage and our hope. Guide us in virtue to lead the world. Virtute et sapientia. May we remain Uganda Mothers University, a place of love, where it is good to be. Guide us in wisdom to lead the world. Virtute et sapientia.
you.